Myself, sir.
Go ahead.
So anesthesia for fetal surgeries. Prerequisites. The prenatal diagnosis techniques should identify the malformations and exclude other lethal malformations. The defect should have a defined natural history and
Okay,
progress.
I'll just show you the questions for that. We can go ahead with that. Okay.
Yes.
Is it visible?
Yes, sir.
Now, here are the questions for fetal surgery. What is the definition of fetal surgery?
Surgery done in a fetus. It's like an in utero procedure that we can repair a defect which is possible and can reverse the injury post.
Surgery done on an unborn baby. That is a very simple way of saying surgery done in a baby which is not born, unborn baby, where you can do a surgical procedure to ameliorate the condition becoming worse. Okay? What is the advantage of fetal surgery?
We can make the defect which is possible and this can be reversible, which can further prevent the process of injury and further the healing is better.
Healing is good because of the continuous nutritional and blood supply, because you allow the pregnancy to continue after completing this fetal surgery most of the time, except for exit procedure where after the repair the baby is also delivered. Whereas surgeries that are done during the mid-gestation period, you allow the pregnancy to continue. So that is the second advantage. One is you are reducing the severity of the abnormality. Second is you are allowing a good interior for the baby to grow with a normal blood supply and nutritional supply. Anything else? Does the mother give any protection to the baby during pregnancy? Why we want the umbilical perfusion, placental perfusion to go on till as much as possible? Apart from supplying the nutrition and oxygenation, what else does the mother supply to the baby? See, when they do a normal delivery, they squeeze the umbilical cord. What is that for?
Milking of the cords, sir.
Why milking is done? What is the purpose?
To increase the HP level, the iron content.
System. All the immune factors are all pushed back into the baby. Okay, so the immune system gives a protection against infections. So these are the advantages of the fetal surgery. Now, what are the types of fetal surgery? You know.
Minimally invasive fetal surgeries, mid-gestation open procedures, and exit procedures, which is ex utero procedure.
Okay. What are the indications for fetal surgery?
Indications when the baby is having a fetal anemia thrombocytopenia, which requires intrauterine transfusions. Lower urinary tract obstruction, which is presenting with the oligo renal dysfunction decompressions. Twin reversed arterial perfusion, which is TRAP, presenting with the high curve. Then twin to twin syndrome, presenting with the reduction in blood flow in the donor twin and increased blood flow in the recipient twin, presenting also with the oligopolyhydramnios. Other than that, congenital diaphragmatic hernia with a severe pulmonary hypoplasia. Then meningomyelocele presentation with hindbrain herniations and which intervened can reduce the cord damages. Then sacrococcygeal teratoma, which can lead to hydrops or cardiac failure in utero itself. Other than that, congenital cystic adenomatoid malformations in the lung and fetal airway compromises.
So you can classify them into anatomical conditions which affect the baby, then classify it into twin pregnancy complications or anomalies. Third is anomalies of the placenta, membrane or the umbilical cord. Okay, so these are all the ways you can classify the indication and then enumerate the conditions that you have mentioned. Now, what are the steps of anesthesia for fetal surgery?
Starting with the pre-op assessment and the counseling, effective communication should be done among the members, which is a multidisciplinary approach. Risk-benefit ratio of the procedure unbiased, and the outcomes and the complications should be discussed in detail. And we should give other alternative approaches and termination options also. The mother should be informed about the timing and the mode of delivery, future reproductive implications, etc. Coming to the pre-op considerations, complete maternal history and examination, fetal workup should be done. Imaging should be done for the correct exact location, the fetal weight, and we should also plan for the emergency delivery depending on the viability. And as usual, NPO status, anti-aspiration, antiemetic prophylaxis, and here procolytics are given in the pre-op itself. We prefer indomethacin in the oral or rectal route, which should be informed to the mother. Then we also should set the OT temperatures appropriately. Then we should arrange for the warm blankets, warm fluids. Then the blood products, in case we are expecting a blood loss, which is not well held in fetus. In intra-op, you go for
So that's the disconnection there.